Good morning and welcome back to this channel, the place where real science meets real life for seniors who refuse to simply accept aging without a fight. If you've spent any time on YouTube looking into senior health, you've probably seen videos with titles like 9 medications causing dementia, dramatic numbers, scary music, a countdown format. And here's the frustrating part. There's a real, legitimate area of medical research buried underneath all that drama. It's called anticholinergic burden, and it's something geriatric doctors and pharmacists actually do think about carefully. But when this topic gets turned into clickbait, it usually gets two things wrong. It exaggerates the numbers, and it tells you to ask your doctor for a specific replacement drug by name, which sounds helpful, but is actually a pretty reckless thing for a YouTube video to do, because the right alternative depends entirely on your specific health history. So in this video, I'm going to do this topic properly. I'll explain what anticholinergic burden actually is, walk through what the real research says, including where that research disagrees with itself, because in medicine, that happens more than people realize, and tell you exactly what a useful conversation with your doctor or pharmacist looks like. I won't tell you to stop taking anything. I won't name a safer replacement drug for you to request. What I will do is make you a genuinely informed patient, which is a much more useful thing for me to give you than a scary list. Quick disclaimer before we start. This is educational content, not medical advice, and if you're currently taking any of the medication types I mentioned today, especially benzodiazepines or antipsychotic medications, please don't stop or change anything without talking to your prescriber first. Some of these can have serious withdrawal effects if stopped suddenly. The goal here is information, not instructions. If that sounds useful, stick around. And if you want more videos that go check what the actual research says instead of repeating clickbait stats, subscribe. That's the entire purpose of this channel. What anticholinergic medications actually are. Let's start with the basic biology, because once you understand the mechanism, the rest of this makes a lot more sense. Acetylcholine is a neurotransmitter, a chemical messenger in your brain and body. It plays a role in memory formation, attention, muscle control, and a long list of other functions, including things like saliva production, digestion, and bladder control. Anticholinergic medications, as the name suggests, work by blocking acetylcholine's activity, either in the brain, the body, or both, depending on the specific drug. Here's what makes this category tricky. Anticholinergic effects aren't limited to one type of medication. They show up as a side effect across a surprisingly wide range of drug classes. Some antihistamines, some medications for bladder control, some older antidepressants, some medications for nerve pain, and some psychiatric medications all have anticholinergic properties to varying degrees, even though they were designed for completely different purposes. Some of these are available over the counter. Most people taking them have no idea they share this particular biological mechanism. The acute, short-term side effects of anticholinergic drugs are well documented and not particularly controversial. Drowsiness, dry mouth, constipation, blurred vision, and yes, short-term memory and concentration problems while the drug is active in your system. Doctors have known about these immediate effects for decades. Where the research gets more interesting and more genuinely uncertain is the question of whether long-term, cumulative use of these medications is associated with a lasting increase in dementia risk, even after you stop taking them. That's the actual scientific question at the center of this topic. Let's look at what the research says. The real research, and where it disagrees. The most well-known study in this area comes from Dr. Shelley Gray and colleagues at the University of Washington, published in JAMA Internal Medicine in 2015. This was a prospective cohort study following nearly 3,500 older adults for an average of more than 7 years, and it used pharmacy fill records rather than relying on people's memory of what they'd taken, which is a more reliable way to measure medication exposure than earlier studies had used. The findings were genuinely striking. People with the highest cumulative anticholinergic exposure over the study period had a 54% higher relative risk of developing dementia compared to people who took none, and a 63% higher risk specifically for Alzheimer's disease. Importantly, the study found a dose-response relationship, meaning the risk increased progressively with higher cumulative doses and longer duration of use, which is exactly the pattern researchers look for as a signal that an association might be meaningful rather than coincidental. The study's accompanying editorial in the same journal issue noted that the cognitive effects appeared to persist even in people who had stopped taking the medications, which challenged the older assumption that anticholinergic side effects on cognition were fully reversible. A second large study, published in 2019 in JAMA Internal Medicine by Carol Coupland and colleagues in the UK, looked at an even larger population, nearly 59,000 people diagnosed with dementia, compared to more than 225,000 matched people without dementia. This study found statistically significant associations between dementia risk and several specific subcategories of anticholinergic drugs: anticholinergic antidepressants, anti-Parkinson medications, antipsychotic medications, bladder antimuscarinics, and anti-epileptic drugs. The researchers' stated conclusion was that these drug categories should be prescribed with caution in middle-aged and older adults. Notice, that's a caution and monitoring conclusion, not a stop taking these conclusion. So that's two large, well-designed, peer-reviewed studies pointing in a concerning direction. Here's where I want to slow down and do something most videos on this topic skip entirely. Looking honestly at where the research pushes back on itself. At least one published letter to the editor responding to the original 2015 Gray study raised the concern that the findings might be affected by residual confounding, meaning some other factor not fully accounted for in the analysis could be driving part of the association. This is a completely normal and healthy part of how science self-corrects, and it doesn't mean the original study was wrong, but it does mean the picture isn't perfectly settled. This pattern, strong initial findings followed by genuine scientific debate, shows up even more clearly when we look at two related drug categories: proton pump inhibitors and benzodiazepines. And I think walking through this debate honestly is actually the most useful part of this entire video, because it shows you what real unresolved medical science looks like, instead of pretending everything is settled when it isn't. The PPI debate, a great example of science correcting itself. Proton pump inhibitors, commonly used for heartburn and acid reflux, are a great case study here because the research genuinely went back and forth. An early, widely cited study in this area, published in JAMA Neurology in 2016, examined data from over 70,000 people aged 75 and older in Germany, and reported an increased dementia risk associated with regular PPI use. Other early cohort studies, including one from Taiwan, found similar elevated risk estimates. These studies got a lot of media attention, and it's easy to see why PPIs are taken by an enormous number of people worldwide, so any real cognitive risk would matter for public health in a big way. But then, more rigorous follow-up research started complicating the picture significantly. A prospective study from Kaiser Permanente, Washington, following nearly 3,500 adults aged 65 and older over an average of 7.5 years with careful pharmacy-based exposure tracking, found no association between PPI use and dementia risk at all, including no association even at the highest levels of cumulative exposure. A separate large meta-analysis covering more than 642,000 patients across multiple studies similarly found no significant overall association between PPI use and either dementia or Alzheimer's disease specifically. And a 2023 post-hoc analysis of a large randomized trial called ASPREE, looking specifically at PPI use in community-dwelling older adults, also found no association with dementia or measurable cognitive decline. A more recent updated meta-analysis published in 2026 summarized the situation well. There's a lack of consistent evidence supporting a link between PPI use and dementia risk overall, largely because of significant differences between how various studies were designed and conducted, though it noted some signal of elevated risk specifically in adults over 65 and in certain regional populations. suggesting the picture may still depend on who you're looking at and how carefully confounding factors were measured. So what's the honest takeaway on PP is specifically? The dementia link that gets repeated constantly online is based on real early studies, but it has not held up consistently in larger, more rigorous follow-up research, and several well-conducted studies have found no association at all. This is exactly the kind of nuance that gets erased when someone wants to give you a scary, confident-sounding number. The real, current scientific position is closer to uncertain and actively debated than proven 44% increased risk. And I'd rather tell you that honestly than repeat a number that the field itself has moved past. The benzodiazepine debate, reverse causation. Explained benzodiazepines, a class of anti-anxiety and sleep medications, present an even more interesting scientific puzzle, because the disagreement here centers on a specific concept called reverse causation, and I think understanding it will change how you think about a lot of health headlines, not just this one. Several meta-analyses have found that long-term benzodiazepine users have a higher relative risk of dementia compared to people who never used them, with pooled odds ratios in the range of roughly 1.3 to 1.8 in some reviews, meaning somewhere between a 30% and 80% relative increase, depending on the specific analysis. On the surface, that sounds like clear evidence of harm. But here's the problem researchers have wrestled with. Anxiety, sleep disturbances, and agitation are themselves recognized as possible early symptoms of developing dementia, sometimes appearing years before a formal diagnosis. So when researchers see that people who later developed dementia were more likely to have been prescribed a benzodiazepine, there's a genuine question. Did the benzodiazepine contribute to causing the dementia? Or were doctors simply prescribing benzodiazepines to treat early symptoms of a dementia process that was already quietly underway, undetected, for other reasons? This second possibility is called reverse causation, and it's a serious methodological challenge in this specific area of research. Researchers have tried to test this directly. One approach. If reverse causation explains the association, then people who started taking benzodiazepines very close in time to their dementia diagnosis should show a stronger association than people who started taking them many years earlier, because the early dementia symptoms would more plausibly have triggered the prescription. Some studies have found exactly that pattern, which supports the reverse causation explanation. But other research has found that the association persists even in people who used benzodiazepines for more than 10 years before their diagnosis, which is harder to explain through reverse causation alone and supports more of a genuine causal contribution. A 2024 study published in BMC Medicine, which included brain imaging data in addition to dementia diagnoses, found no association between benzodiazepine use and either dementia risk or imaging markers of neurodegeneration, directly contradicting earlier meta-analyses, and the authors specifically noted that earlier positive findings may have been influenced by reverse causation and confounding by indication. Other large prospective studies have reached similarly null conclusions, with at least one explicitly stating that the results do not support a causal association between benzodiazepine use and dementia. So where does that leave us? Genuinely uncertain and reasonable experts in the field disagree. What's well established beyond dispute is that benzodiazepines cause real, measurable acute cognitive impairment while they're active in your system. Slower thinking, sedation, impaired memory formation in the short term. That part isn't controversial at all. What's still being actively debated is whether long-term use causes a lasting increase in dementia risk after accounting for reverse causation, or whether the association we see in some studies is largely explained by the fact that early dementia symptoms themselves often lead to a benzodiazepine prescription in the first place. I want to be really clear about something important here. Regardless of how this scientific debate eventually settles, benzodiazepines carry serious, well-established risks for older adults that have nothing to do with dementia and aren't contested at all, including a significantly increased risk of falls, fractures, and confusion, especially when starting the medication or increasing the dose. That's precisely why benzodiazepines appear on the American Geriatric Society's Beers criteria, a respected, regularly updated list that flags medications requiring extra caution in older adults. And, critically, if you are currently taking a benzodiazepine regularly, please don't stop suddenly on the basis of anything in this video. Abrupt discontinuation can cause serious withdrawal effects, including seizures in some cases. Any change needs to happen gradually, under medical supervision. What you should actually do with this information. So, given everything we just walked through, genuine evidence of risk for some drug categories, genuine scientific disagreement for others, what's the actually useful, responsible takeaway? Here's what I'd suggest, and notice that none of it involves me telling you what to take instead, because that's a decision that has to account for your specific health history, your other medications, and your doctor's clinical judgment, not a YouTube video. First, ask for a comprehensive medication review. This is a real established clinical practice, not something I'm inventing for this video. Pharmacists and geriatricians can calculate something called an Anticholinergic burden score or cognitive burden score across your entire medication list, prescription, over-the-counter, and supplements, using validated clinical scales designed for exactly this purpose. If you're taking several medications regularly, especially if you're over 65, this is a genuinely useful thing to request, and many pharmacies and primary care practices can do this as part of a routine visit. Second, bring a complete list, including over-the-counter products. A lot of anticholinergic exposure comes from things people don't think of as real medication: allergy pills, sleep aids, and some cold and flu products. Your doctor or pharmacist can't account for what they don't know you're taking. Third, ask about the specific risk-benefit picture for your situation, not the internet's. If a medication is genuinely helping you and the evidence for cognitive risk is contested, as it is for PP is and arguably for benzodiazepines based on what we just covered, that's a meaningfully different conversation than if you're taking something with stronger, more consistent evidence of risk for a condition that has well-tolerated alternatives. Fourth, never stop a medication abruptly based on something you watched online. I know this is the least exciting advice in this entire video, but it's also the most important. Some of these medications, particularly benzodiazepines and certain antidepressants, require a gradual taper under medical supervision to avoid genuinely dangerous withdrawal effects. The goal of an evidence-based video like this one is to make you a better informed participant in your own healthcare decisions, not to make those decisions for you from a script. Fifth, hold on to some healthy skepticism toward dramatic health content generally, including, frankly, content like this. If a video gives you a suspiciously precise percentage, 54% increased risk, 120% higher, a reasonable next step is to ask, is that number from a single study, or does it hold up across multiple studies? Has anyone tried to replicate it? Does the video mention any contradicting research, or does it only show you the scariest number it could find? In this video, I tried to show you both sides on purpose, because that's what actually happened in the published research, and I think you're better served knowing that the picture is genuinely mixed in places than being handed a clean, dramatic story that isn't fully accurate. To sum up, anticholinergic burden is a real, legitimate area of concern in geriatric medicine, with solid evidence, including 2 large, well-designed studies connecting cumulative anticholinergic medication use to increased dementia risk. That's worth taking seriously and worth discussing with your doctor or pharmacist. At the same time, some specific drug categories that often get lumped into this conversation, particularly proton pump inhibitors and, to a real but more debated extent, benzodiazepines, have considerably more mixed and contested evidence than dramatic online content tends to suggest, including several well-conducted studies finding no meaningful association at all. The single most useful thing you can do with this information isn't to panic about your medicine cabinet. It's to ask your doctor or pharmacist for a full medication review. Bring your complete list, including over-the-counter products, and have an honest conversation about your specific risk-benefit picture. That's a genuinely empowering step, and unlike a lot of health content out there, it's one I can responsibly recommend without needing to exaggerate a single number to make the case. If this was useful, the like button helps more people find an honest version of this topic instead of an exaggerated one. Subscribe if you want more breakdowns like this. And let me know in the comments, has a doctor or pharmacist ever walked you through your full medication list for things like this? I read every comment. Take care of yourself, and I'll see you in the next one.